Good afternoon to one and all. My topic for today is diode laser vaporization of prostate. I'm going to talk about the equipments required for this procedure and I'm going to give an overview of the procedure. Regarding the equipments, I'm dividing them into three categories. One is the instruments we are going to require. Second is the laser machine. And third is the fiber which we are going to require. I'll go to each of the details first. First, we'll be talking about the instruments required. There are basically three instruments required for this procedure. One is the outer sheath, other is the inner sheath, and the last is a telescope. The laser resectoscope I'm dividing into the outer sheath, the inner sheath, and the standard telescope. This is the Karl Storz 23 French continuous irrigation outer sheath of the resectoscope. The special feature of this resectoscope is it is an oval design and it's not a circular sheath. As you can see from this diagram, the vertical axis is 23 French. That is what we call it as a 23 French sheath. But if you see on the horizontal plane, it is only 18 French. So this is one of the smallest sheaths available for doing a prostate surgery. The major advantage of having such a small dimension is that the stricture lengths are really low on this procedure. As you know very well, in the Indian urethra, it is very difficult to use 26 French sheath, and anything less than 24 is a major added advantage for us. Coming to the inner sheath. The inner sheath has a 7.5 French channel. It is a fairly large channel for allowing our laser fiber. The telescope that we require for this procedure is the standard 30-degree 4 mm telescope which we regularly use for cystoscopy. So there is no requirement to purchase a telescope. Only the outer and inner sheaths need to be purchased for this procedure. This is the final picture of the instrument with the fiber in situ. As you can see, it is a simple straightforward design. All three, the outer sheath, inner sheath, telescope, and then the fiber. The machine we are going to use for this procedure, the laser machine, is called Leonardo Dual 200. It is from a German company called Biolitec. Coming to the laser specifications, it is called the Dual 200 because there are two wavelengths in this machine. Unlike our holmium and thulium lasers, where there is only one wavelength, here we are having two wavelengths. One is the 980 nanometers and the other is the 1470 nanometers. We have a maximum power here of around 200 watts with 40 watts of 1470 nanometers and 160 watts of 980 nanometers. So these are individually adjustable. So I can choose how many watts I want in whichever wavelength I want. Aiming beam also, there is a choice between the green aiming beam and the red aiming beam. Two aiming beams are available. We can choose either of the two. Treatment modes available are, the common modes we use in urology is CW, which is continuous, and the pulse mode, either a continuous mode or a pulse mode. The other modes are basically for vascular surgery. This laser is used extensively in vascular surgery for varicose veins as well. And there are a lot of dermatological applications for which there is a derma mode. Those modes we don't use in urology. Power supply. The main point here is it has a standard power supply which will fit into any socket in our OT. Unlike the high power holmiums, you don't have to have separate power supply and other equipments. The design and dimensions are very compact and the total weight is only 15 kg. So it's a highly portable machine. So why was this 980 nanometers chosen? So this slide tells us about wavelength and tissue interaction. As you can see from here, the 980 nanometers is absorbed equally by water and hemoglobin. What is being absorbed by water means you have a better vaporization property. And what is being absorbed by hemoglobin means you have better hemostatic property. So 980 nanometers has a superior hemostatic property, while 1470 nanometers has been added to this laser because it has a superior vaporization property. Your speed of vaporization can be increased by adding on the second laser wavelength. Coming on to the fiber types. There are multiple fiber types available. There are bare fibers with flat tip, ball tip, conical tip, but these are mainly used for enucleation. This machine can be used for diode enucleation of the prostate as well. But the ones we use for vaporization are the first two. One is the excavator fiber, other is called a twister fiber. I'll be coming to the twister fiber discussion. This is how the fiber is supplied. This end is the one that goes into the machine. This is the area where we hold the fiber, and this is the tip. I will show. This is the tip, zoomed part of the tip of the fiber. As you can see, it has a 30-degree angulated large tip. This looks similar to a TURP loop end. This large angulated tip is the one that helps in giving us an increased surface area. So the surface area where the laser is being applied has been increased by having this type of a design. Coming to the fiber comparisons. Initially, when we started this procedure in 2009, the fiber available was this, the side firing fiber. The problem here was it was a non-contact fiber. If you by mistake kept on touching the prostate, the fiber used to break. It was a side firing fiber. There was a mirror at the end of the fiber and it was reflecting the light, laser light towards the side. The other problems we saw was it was having a small area of vaporization, only 2 square mm. So the rate of vaporization was also quite slow, 0.5 to 1 grams per minute. And the other problem here was being a smaller area of vaporization, the energy, laser energy was getting focused onto a smaller area, and this was leading to post-operative dysuria. Now when you come to the newer twister fiber, you can see that the area of vaporization has increased to nearly 9 square mm. And so the rates of vaporization have also gone up quite fast. Average person can do at least 2 to 3 grams per minute. The proficiency of the surgeon ensures even faster vaporization rates. The amount of watts you use and how much pressure you are applying to the area ensures that you can vaporize much faster. As your confidence level and as number of cases you do goes up, you can increase the wattage and go even faster vaporization. As you can see in the improvement in fiber design, previous fibers had a smaller angulation and a smaller tip, while the newer fibers are having little more angulation and quite a large surface area at the tip. So what are the advantages of these? Increased fiber tip surface area is going to lead to faster and more efficient ablation by vaporization. Now that we are working in contact mode, we are getting a tactile feedback. So we really know how much pressure we are applying and how well the procedure is going. We are having better control of the fiber tip and the hemostasis is excellent. Now coming to the techniques which are available while using this fiber. There are 2 major techniques which are available. One is the twisting movement which you are seeing on the left, and the other is the TURP-like movements which you are seeing on the right. This twisting movement is a sideways or transverse axis movement, while the TUR-like movements are longitudinal axis or forward-backward movements of the fiber. The next slide is going to be regarding the 2 techniques which I have spoken about, the older side firing fiber technique and the newer twister firing technique. As you can see in the slide and the video on the left, the side firing technique is a slow technique, and you can see very well it's in a non-contact mode. You are seeing the fiber a few mm away from the surface. While in the newer twister fiber technique, it is a contact mode, and you can see the vaporization is quite fast with a significant amount of bubbles which show the speed at which we are vaporizing the prostate. Coming to the guidelines, as per the EAU 2020 guidelines, monopolar TURP is still the current standard surgical procedure for men with prostate less than 80 ml. Coming on to the laser surgery. What are the technologies available and what are the lasers available? There are 2 major technologies. One is the enucleation technology and the other is the vaporization technology. And the lasers available, as we know, are the holmium, the thulium, diode and the KTP. These are the commonly available lasers as on date. So our indications for vaporization are going to be large prostates greater than 80 ml, patients on antiplatelet and anticoagulant drugs. What are the major advantages in laser vaporization? So shorter hospital stay, 2 to 3 days. Although in Germany, they are doing this as an outpatient surgery and discharging them same day. But here in India, we prefer to keep them for 2 days. We remove the catheter after 24 hours, see how they void for 24 hours, and then we send them home. There's a decreased blood transfusion requirement. It is safe for patients on antiplatelets. And there is a significantly decreased stricture urethra rate because our sheath is quite small in dimension. I'm going to compare the two major technologies here, enucleation and vaporization. I'm going to talk more about our advantages of our vaporization technology. The learning curve here is 10 to 15 cases probably, while in enucleation, this is a steep learning curve, at least 25 to 50 cases before you can be proficient in enucleation technology. The second major advantage of vaporization is you can convert to conventional resection at any time. If, for instance, there is a machine breakdown, fiber breaks down, any of those things happen, you can just take your TRP loop and complete the procedure. But in enucleation, once you have started, till you complete the morcellation and take out the pieces, it is difficult to switch over to conventional, or you cannot stop the procedure also. In vaporization, there is no morcellation required. So at the end of 1 hour, once you finish vaporizing 80 or 90 grams, that's it, your procedure is over. There is no further requirement of another 45 minutes or an hour for morcellating, removing the pieces and all that. You can just put the catheter and come out. The major difference is that this is a single-use fiber. Because the tip is enlarged tip, it tends to break after that. So it is basically a single-use fiber. The monetary comparison, in vaporization, there is no morcellation device needed, so that expense is not there. The diode laser is less costly when compared to the high energy holmium device. The 100 watt holmium device is a very costly device. When compared to that, the diode is less costly. The diode cannot be used for stones. It can be used only for soft tissue, while the holmium high energy can be used for stones. That is one advantage of the holmium device. The most important point here, which I'd like to discuss, is that this device is a mobile device. That means it can be shifted and shared very well with other urologists in the same city. The holmium, on the other hand, is not a mobile device. Shifting or major movements can lead to mirror misalignment, and there could be less output or even no output. So unlike this device, our device is a solid state device and can be shifted and shared, so bringing down the cost of the device. The only thing is that the single-use fiber is a costly fiber. Coming to the summary of evidence and recommendations for diode laser treatment of the prostate, these are the latest EAU 2020 guidelines. The laser vaporization of prostate has a high intraoperative safety with regard to hemostatic properties when compared to TRP. This is a good level 1B evidence from EAU. And the catheterization time and hospital stay are in favor of diode laser. When we come to post-operative complications like severe storage symptoms or persisting incontinence, these are mostly to do with the older papers where we are using 120 watts and we are using a side-firing fiber, which was leading on to more concentration of energy at one point, leading on to severe post-operative dysuria. Coming to the apex, now we learn that coming to the apex, we reduce the power when you're doing the apical lobes, and this temporary stress incontinence post-procedure has also come down. Nevertheless, in very large prostates with big apical lobes, there is already a significant stretch of the sphincter by the lobe itself, and in the postoperative period, when you remove so much of the prostate, the patient tends to have a temporary stress incontinence which may last 1 to 3 months. It is not a very significant finding. That is why they are given only a level 3 evidence. Newer papers will address this. Coming on to the enucleation with this laser, this has shown a efficacy similar to the bipolar enucleation in the short term. And with regard to blood loss, catheterization time and hospital stay, the diode enucleation is far superior to using the bipolar enucleation. This is also level 1B evidence. Coming to the last point regarding hemostasis in patients using anticoagulant therapy. In patients with antiplatelet therapy, we have seen that the post-operative period, there is not much hematuria and it is quite okay. But patients who are on warfarin for mechanical valves or other such indications, when we switch over them to the low molecular weight heparin and do the procedure, the intraoperative period looks quite all right. But in the postoperative period, we do see some mild bleeding. And with irrigation and conservative management, we are able to manage these patients. And that is why they given only level 3 evidence. It is not a strict contraindication or a problem to this procedure. Thank you. I will now hand over the session to Dr. Vikram.
That was